relationship with any company. Also, I used to be partner of a company that distributed medical products in Venezuela, but it broke down 5 years ago, so I don't have any conflict of interest. So we are going to talk about sleep apnea and the relationship, if there is any, with cardiovascular diseases. Whenever I think about sleep apnea, I remember this guy. I don't know if you remember him. He killed people when they went to sleep. And that's what the sleep apnea do, and mostly because of cardiovascular diseases. So the thing that I'm going to try to do in the next few minutes is to try to reveal, to present some ideas of the relationship, if there is a causal relationship between sleep apnea and cardiovascular diseases, and if so, if it is worthwhile to systematically assess sleep habits in patients with cardiac problems. What I really think that a good conference should be just like a mini-script. It should be short enough to be attractive and should be long enough to cover all the subject. I'm sure we won't have time to cover all the subject, but I would like you to enjoy the conference, the presentation. This slide is very important because this is the reason why some of the ideas that I'm going to present today is not very well known in the general population and many doctors as well. You can see that before 1980 there were almost no publications about sleep apnea. From then it became increasing pattern of the publications, but we'll never find 2,000 papers a year. So it's a brand new medical problem like AIDS from 1981, but very unknown one. What is apnea? I hope you understand the word apnea. Apnea means non-breathing, the stopping of breathing. So by definition it should be more than 10 seconds. And we say that it is obstructive if there is a fall to breathe. People with apneas, with the sleep apnea, they are really choking for several seconds and even minutes until they suddenly rebreathe again. That's an apnea, an obstructive apnea. But we also have hypapneas. This is a non so severe degree stage of apnea where they can still enter air to the lungs, and this produces vibration of the soft palate, and he snores. This is hypapnea. By definition, is at least 30% of the reduction of the airflow associated with oxygen desaturation, because it's asphyxia as well. It's just a non-deeper like an apnea. Etymologically speaking, obstructive sleep apnea syndrome is the signs and symptoms related to the asphyxia, the apnea, caused by the obstruction, the closure, the collapse of the upper airway when we sleep. And how is it possible? How is it possible that you just fall asleep and you choke? That you stop breathing? That you have an asphyxia? How is it possible? Well, it's easy. It's easy to understand. When we sleep, whenever we sleep, our muscles relax. All of it. In all our body. So, our hands fall down. Huh? During REM sleep, we have completely atonia. We have no muscle strength. And the airway is mostly only muscular tissue. It's a tubular muscular tissue that when relaxed, it closes. It closes. It happens to everybody always. But most of the time it doesn't happen anything because they still have room for the air to enter to the lungs. But if the airway is already obstructed, collapsed or reduced like this one, for instance, this tonsillar hypertrophy, it's already collapsed or closed the airway, and when he sleeps, as everybody, it collapses and completely closes an apnea. So he will stop breathing for minutes until he breathes again. And if there is still some air coming in, he will stop. What is the pathophysiology of the problem? It's very easy, and if you understand this, you will understand the signs, symptoms, outcomes, and of course the treatment. Anemia causes asphyxia with hypopnea, hypercapnia, and acidosis, as always. If you have several minutes without breathing, you die. And our body reacts against this asphyxia, producing hormones, a lot of them, catecholamines, glucocorticoids, and insulin, many others that react, and they have acutely and chronically problems, of course, related to this overproduction of hormones. So we will have arrhythmias, we will have hypertension, we will have sudden death, we will have left ventricular hypertrophy, we will have pulmonary hypertension, we will have nocturia, going to the toilet several times at night. We will have polycythemia, we will have overproduction of red blood cells because they don't have enough oxygen, so they produce more red blood and they are ruddy. But this is not the only problem with the sleep apnea. The other several problems is that they are sleeping and they are choking, so they wake up to breathe, to rebreathe again. So they are waking up every minute, every 2 minutes. So they never sleep deeply, they never sleep all night long, they never sleep restorative, so they will wake up in the morning tired, they will have somnolence during the day, and they will just fall asleep when they are doing any activity, where they are studying in a conference, watching TV, studying, and very importantly, driving or walking. And this is one of the most important causes of traffic accidents and occupational accidents as well. The signs and symptoms are very easy, and you understand them, not only what I've listed here, because the pathophysiology is very understandable. If you snore, one of the cornerstones of the diagnosis, you have sleepiness. And if you have hypertension or obesity, if you have all this, the clinical diagnosis is already done. He has a sleep apnea. This person has a sleep apnea. Witnesses apneas as well. If somebody tells you that you choke at night, awakening with choking, headache, nocturia, cognitive impairment, no restorative sleep, amnesia. Who was I going to phone? Where are my keys? That's people like that. They are tired all day. They have less sexual desire. Disturbed mood, bad temper, depression, muscular pains, among many other signs and symptoms. Who has a higher risk? Men, obese people, anatomic disturbance like the tonsillar hypertrophy that I showed you before, comorbidities, muscular or neurological diseases can cause this too. Family history, if my parents have this problem, it's a risk factor too. And very important, toxics like tobacco, alcohol, and very importantly, hypnotics. The drugs that we erroneously prescribe people when they come to visit us and tell, I don't sleep well. They don't sleep well because they are choking, because they are dying at night. And we could prescribe them hypnotics. We are killing them. Menopause, age, as other, but this is the most frequent one. Obesity, the most frequent high-risk group. Fat distribution is not only done outside, it goes inside too, reducing the airway. You can see here this fat person with this double chin, his belly coming from the neck. He has his hands here, and you can see that the airway is almost closed. When he sleeps, like everybody, it will collapse and he will have sleep apnea. What are the consequences, the outcome, the complications of sleep apnea? Hypertension, coronary artery disease, heart failure, arrhythmias, cerebrovascular disease, diabetes, metabolic syndrome, obesity, I already told you, traffic and occupational accidents, and other psychological problems like mood, behavioral disorders, and poor performance, and are some of the consequences. So we're going to talk today about the relationship of cardiovascular disease and sleep apnea. This brand new publication, last year publication, says cogent data confirm the association between obstructive sleep apnea and hypertension. Words like robust, strong, consistent are many times mentioned in the paper. We haven't found an evidence-based publication about this association, but we are going to try to reveal if there is a causal relationship. Almost 10 years ago, it was published that sleep apnea is a primary risk factor for hypertension. Whenever we think that there is a causal relationship between a risk factor and disease, we should evaluate several criteria. If we found all this, we could say that there is a causal relationship. For instance, if I throw this cellular phone to the floor, it will break. There is a causal relationship, but we should evaluate if there is strength. If I throw it, it breaks. And if there is a dose-response relationship, if I throw it stronger, it will more easy break. If there is a temporal sequence, it doesn't break before I throw it. Okay, I first throw it, then break. If there is consistency, every time I throw it, it breaks. And if there is a logical explanation, a biological plausibility for this result. Let's see if it happens. If we can see about strength, almost 20 years ago, it has been several studies published about the relationship between hypertension and sleep apnea. This is very well known one, a large community study, and we can see here with crosses and asterisks that with a poor probability that there is a statistical significance, strength, epidemiological strength of the association between one and the other. You can see here that having sleep apnea makes you 3 times more frequent the hypertension than people that doesn't have sleep apnea. More crosses here, statistical significance. We can see that the odds ratio or the relative risk is 5-fold the risk to develop hypertension among people with sleep apnea. And when we adjust for other confounders like age, sex, obesity, alcohol, etc., we still have 3 times more frequent hypertension among these people. If there are dose-response relationship, if I have higher or deeper degree of sleep apnea, I should be having a higher hypertension, or more frequent I will develop hypertension. And it says here that every apnea, every event per hour will increase the risk by 1%. But we can easily see in this graph here, you can see that if we have 70 per hour, 70 events of apneas per hour, we double the risk than if we have only 20. So if we get worse in sleep apnea, we will have more hypertension. And if we improve, it should be go the other way. And actually it does. This is a study that used CPAP to treat effectively people with sleep apnea, and when they improved the sleep apnea, the blood pressure fell down. Is there a correct temporal sequence? What was first, the sleep apnea or the hypertension? Easy. About 60% of the patients with sleep apnea have hypertension, whereas only 25% of people with hypertension have sleep apnea. So first is sleep apnea, and then it develops to hypertension. Consistency about results. Last week there were almost 2,900 papers about this relationship. All of them, or most of them, are consistent. Surveys, cross-sectional studies, longitudinal prospective cohort studies, clinical trials have proved that there is a consistency in the results, also in basic animal models. Is there a biological, logical explanation why sleep apnea produces hypertension? Yes, there is. We have intermittent, frequent hypoxia and hypercapnia, our hemodynamic response to apnea, repeated arousal. If I wake you up every minute, every day, you will have hypertension even if you don't have sleep apnea, just because of waking up. Okay? The sympathetic tone is increased, catecholamines production is the effect of negative intrathoracic pressure, increased platelet aggregation, fibrinogen, homocysteine level, and there is a poor production of nitric oxide. So it's a machine for making hypertensive people sleep apnea. You can see the sympathetic responsiveness against hypoxia and hypercapnia. This is an apnea. This is an obstructive sleep apnea. He's not breathing. And then he rebreathes. And you can see that the sympathetic tone is increased, and they also have hypertension. Try to do this now. Stop breathing for a couple of minutes, if you can, and you will have hypertension. Interleukin and catecholamine levels, nitric oxide production, they almost don't produce nitric oxide. So, indeed, it's a machine for hypertension. And there are some other explanations, mechanisms by which sleep apnea produces hypertension, but other cardiovascular disease as well. A very important consequence is refractory hypertension. When we have somebody with hypertension and we take several pills at the higher dose and the blood pressure doesn't control, it's because 9 of every 10 of these people have sleep apnea, and they will never have normal tension because they need the high blood pressure to pump oxygen to the body. You have to treat them before. The other very important problem is this. Whenever we sleep, if we don't have sleep apnea, we normally drop our blood pressure during night. But people with sleep apnea have hypertension at night. So, we can see here that having this non-dipping pattern is a very high risk group for cardiovascular diseases. So, how many of us, when we are taking a history of somebody with hypertension, ask them about their sleep habits, if they snore? Who is the doctor? None of you? Well, we don't. Well, I do. But most of us, we don't do. We just check the blood pressure, put medicine, go. The next one. But you can see that it's a very, very wrong way to treat them. And why? Why does it happen? The same author asked himself, we don't think about this disease. It's an unknown disease, sleep apnea. So in the Joint National Committee report, they didn't even mention about the sleep apnea. And the textbook about hypertension, they pay little attention to this problem. Nevertheless, in the last publication, the 7th report, this one, it states that one of the objectives to treat a person with hypertension is to reveal identifiable causes of hypertension. And the first, by far, is sleep apnea. And it's not only identifiable, it's treatable. Very easy. So, by many mechanisms, it can make not only hypertension, but many other cardiovascular diseases. You can see 5-fold increase in cardiovascular events, coronary, infarction, cerebrovascular events. You can see here, angina, unstable angina, heart attack, infarction, myocardial infarction with the crosses, heart disease, diabetes, obesity. One of the most frequent arrhythmia, atrial fibrillation. Almost half of the people with atrial fibrillation have sleep apnea. And there are several other very important, even cardiac arrest arrhythmias caused by sleep apnea. People with long-term pacing. Huh? This paper says that they should be systematically, all of them, assessed for sleep disorder of breathing because of the potential cardiovascular effect of this problem. Sudden death. You all know that people die early in the morning or at night. And that is because of sleep apnea. It's not the stars, the moon, sleep apnea. It doubles the risk for metabolic syndrome, diabetics. There is an explanation here. So systematically, all diabetic people should be assessed for this because of the potential treatable risk factor for cardiovascular disease in diabetic people. You may know the risk factor for stroke, hypertension, hyperlipidemia, atrial fibrillation. Everybody knows them. But nevertheless, the most important one is obstructive, and nobody knows that. It's unknown. But it's the worst risk factor for the 5th cause of death. It's not only cardiovascular disease. The family, social life, the personal relationship, the general mood, the capacity to accomplish tasks are severely damaging people that doesn't sleep. People with sleep apnea have less gray matter, preeclampsia, erectile dysfunction. The bed partner, the wife or the husband of somebody that has sleep apnea, she's always waking him up and trying to save him. So they don't sleep well and they have a very bad quality of life. If they are treated, they improve their problems. You remember this film? She was so mean, she became a monster because she never slept. You remember that one? Well, yes, actually we have this severe problem with sleep apnea, sleepiness, and the worst of it is traffic accidents. Actually, if you don't have sleep apnea, not having a sleep apnea is preventive against traffic accident. So it's the first cause of traffic accidents in industrialized world. But the most important of this is that very many people have this problem. If we are in a waiting room like this one, how many of these people have a sleep apnea? And we don't know. We don't assess them. Never. Well, if you think that somebody have this problem, you should refer them to a sleep lab. So they make a polysomnography and they confirm the diagnosis, the clinical diagnosis. If you have a patient like this one, the diagnosis is done. Right? He's fat, she's fat, she's ready. Actually, she's having cyanosis because I don't know how many minutes she haven't been breathing, and she left the train. Or the patient that comes to visit us and fall asleep in the consultation. She has a sleep apnea. But this, only 5 questions, and maybe we don't have to ask him. If everybody go to a cardiologist, everybody, all of them, that's our proposal. We ask them, do you snore? Are you tired during the day? Have somebody seen you with an apnea? Because we don't see ourselves at night when we are sleeping. Do you have hypertension? And we can see that he's fat. We don't have to ask that. You cannot disguise it. So, only 4 questions. Do you know? And if there are 2 of these answers positively, we should send him to a sleep lab. I don't know if you remember the super pill. This very important and I think that very well-known paper that says that if we have a super pill, we take a pill with aspirin, folic acid, antihypertensive, whatever, we should, and give it to everybody, we should reduce by 80% the cardiovascular diseases. I agree with that. But if we think about the sleep apnea and its treatment, and that would be all because we don't have enough time. Thanks you all, and if you have any question, I can answer it before the next presentation. I think it might be yours.
I think it's me, yeah.
Yeah, 5 more minutes, so.
I'll ask a question. So, would it help understanding any kind of problems with airflow into the lungs? Anything to do with sleep apnea, or not at all? Is it not related to?
Sorry, I didn't.
Sorry. Would it help if you understood more about, say, airflow into the lungs and problems from constriction at the throat? Would that help understanding sleep apnea in any way, or not at all?
Well, I haven't talked about treatment,
Mm-hmm.
but it's very, very easily treated disease.
Mm-hmm.
If you bypass this obstruction
Mm-hmm.
or you stent it, it's resolved. If you make a hole in this obstructed airway, it resolves. And actually the results are wonderful, indeed. I have another presentation in a few minutes, but I would really think that it would be better to present the treatment of this and switch. I will ask the scientific committee if I can do that. If I can do that, I could answer your question widely.
Okay.
But in 2 minutes I could do this. This is the treatment, the most efficient treatment for sleep apnea. This is a machine. This machine is a pump, air pump, that takes air through this tube to this mask, through the nose or mouth, and the already collapsed airway opens stent with air and he breathes again, and it's resolved. That's easy. That's all. You can see how it reopens. All the pathophysiology that I explained you, and some that I haven't, it's resolved. You can see that the overproduction of hormones improves, and for instance, reduces the risk of coronary artery disease, infarction. Half, more than a half, instead of untreated people. The atrial fibrillation. The atrial fibrillation is that the heart doesn't work properly. So I told you that half of them, they have sleep apnea, and when we treat them, we get better than control people like us, that we don't have atrial fibrillation. I'll show you a very good one. This is my sister. She had a sudden death because of this. I resuscitate her. And now, a few months after this picture, she came like this. You see, she was this fat, large girl, and now she's like that. And this man became like this in 1 month. And you can see this guy, how fat it is, what it was, because that's me.
Like you.
That's me. That's me.
How long?
A couple of years.
A couple of years. Oh, wow. You're very handsome.
So you can see the changes. The hormone production, all the pathophysiology results absolutely.
How much?
Yeah, don't forget.
How much?
What?
I mean that for if I interest in the program like this, how much does it cost?
Treatment is quite cheap. It's cheaper than the medication that you have to take for hypertension or diabetes or whatever.
Yeah.
And of course, if you won't have a heart attack, you won't have a myocardial infarction and all that. It's very, very cheap. Actually,
That's why they will not be published.
I will certainly ask them to talk more in my later presentation. I have another presentation, but I don't want to do it. I prefer to talk about this if you want. I can explain you more. But we don't have more time, so this is presentation now.
No problem.
The one that funded this study, and our Venezuela is one of the major causes of maternal mortality, morbidity, and also the perinatal morbidity and mortality. It's the second cause of mortality worldwide, and that is because of bleeding and infections in the undeveloped countries. But if resolves as we hope, we will have preeclampsia as the first. The incidence is very high, particularly in non-developed countries like where I live in Venezuela. We can help you with many patients. We have a lot of them. We have more than 20% incidence of preeclampsia among our pregnant women. The morbidity it's huge. We have several problems in pregnant women with preeclampsia: abrupto placenta, eclampsia, intravascular disseminated coagulation, acute renal and hepatic failure, the HELP syndrome and stroke among women, and intrauterine growth retardation, preterm labor, and perinatal mortality very frequent in this population. As I told you before, it's the first maternal mortality cause in developing countries. But if you treat these women in the right way, we can prevent a lot of death, like we can see in the USA and in Europe. It's only the second cause of mortality. But in our country, Venezuela, and actually in our city, Mérida, is the first cause of maternal and perinatal mortality. We have conducted several studies before in Venezuela and in Africa about the relationship between nutritional cofactors and preeclampsia. And we have found these seasonal changes in the incidence, maybe due to problems with the nutrition in these women. Although we don't know the etiology or the pathophysiology of preeclampsia, the oxidative stress is one of the key factors involved. And so we conducted this study in Africa and in some countries in Latin America, Guatemala and Venezuela, and we found that there is indeed a riboflavin deficiency in women with who developed preeclampsia. Only 33% of preeclampsia patients had adequate riboflavin status. So we presume that it should be involved in the pathophysiology of the disease. We actually found that there was a deficiency on riboflavin in several developing countries. It was not our case, but in Africa and some other countries, we indeed find riboflavin deficiency. And we found that 5-fold increase of preeclampsia among women with riboflavin. Vitamin B2, riboflavin, is a precursor of coenzymes, a key factor for some enzymes that are impaired in the preeclampsia status. So the daily need of riboflavin in pregnant women is higher than in normal non-pregnant women. So we can see in this slide that there is indeed huge deficiency among women, pregnant women, in different countries, even in industrialized countries like England and France. We all know that an imbalance between oxidative stress and antioxidants, the lipid peroxides and these antioxidants are focused on the pathophysiology of preeclampsia. So we think that if there is a lack of vitamin B2, we should develop preeclampsia more frequently. So we have the idea that if this deficiency could make a high risk of preeclampsia, and if we could prevent it with high dose riboflavin supplementation. So we conducted this, we tried to conduct this study. I am from Venezuela, but I don't live in Venezuela anymore. We have a dictator there, so we had a very big problem. The health institution is already broken in Venezuela, so we had to stop this study. We couldn't be able to present this. that's why I don't really care about this data, because it's only a pilot study. Actually, we began it in other countries in Africa, but the results were even worse than ours, because we wasn't able to get enough patients, and we couldn't finish in Venezuela. The fact is that we have a public health program called the Program for the Prevention of Preeclampsia, that women, all pregnant women, are selected in high-risk groups and non-high risk. Those women with high risk were also involved in this study. All of them are checked if they are, for instance, primigravid, or if they have previous history of preeclampsia or hypertension, or if they are diabetic or obese, or if they have a multiple gestation. So if any of these criteria was on the patient, we made the randomization. We actually needed 3,000 patients, and we wasn't able to get them. And the purpose was to give supplementation 50 milligrams daily of riboflavin to these people, or placebo, to see what was the outcome. You know the definition of preeclampsia. We use the regular definition of hypertension above 140 or 90 of blood pressure in these women with proteinuria, preeclampsia without proteinuria, pregnancy-induced hypertension, chronic hypertension if they have this hypertension before 20 weeks of gestation, and they have severe preeclampsia if some of these complications, or if they have this blood pressure. So here is Venezuela, in South America, and Merida is the place where the program for the prevention of preeclampsia was. And so we assess these women. If they have any of the criteria, we enroll them. And this is the baseline data. You can see that the randomization was very good, because we have the same numbers in both groups. But we had this problem. We had a huge loss of follow-up, 40%. That's because we had a general strike. I don't know if you remember, we had a strike against Chavez, and the complete health system was closed for several months. And then that's why I have to leave my country. So, we tried some riboflavin and other vitamins levels, and we found that there was compliance in the treatment. But we can see here that severe preeclampsia was more frequent in the placebo group than the women who received riboflavin, as well as preeclampsia, but also blood pressure. The difference between the placebo group and the riboflavin group was statistically significant, the difference between the two groups. So we can see here that these values are the only statistical significant. That's because we didn't have the 3,000 patients that we originally needed. So our pilot study show or suggest that daily doses of riboflavin supplementation given before or around 20 weeks of gestation in high-risk women would decrease the risk of severe preeclampsia or the blood pressure values. We know that only aspirin has been shown that prevents preeclampsia. several other things has been medicine, it's aspirin. But it's the same pathophysiology mechanism and pharmacodynamics. So maybe we should now present this data in order to, we could make in another setting this study conducted in the right way to see if the vitamin supplementation, in this case riboflavin, could prevent preeclampsia. And well, that would be all. Thank you very much, and if you have any question.
What are the adverse effects of too much riboflavin?
Well, it's a natural vitamin. We take it with our foods, with for instance with grains, corn. It's not like liposoluble vitamins that you could have adverse effect. With this hydroflavin, it hasn't been shown that there is an adverse effect. But the doses that we gave it's still low enough. Actually, the women that we had in Venezuela, they have a good riboflavin level in their blood in the placebo group as well. So they were well nourished, our women. It's not the case in Africa, that they have indeed deficiency, but we think that this is a good approach to give a medicine, a medication, a vitamin that doesn't have, or we think that it doesn't have any adverse effect.
I personally want to congratulate, despite any conclusion will come from this study, because there is some start as we have seen. But allow me to use a French philosopher who said, mostly we doctors treat with medicine we little know. That is pertaining the first question. And another thing is the disease which we know just a little, and a patient who we don't know at all. This is even today true, because I am coming from the third world country, as my face explains to you, and preeclampsia is a very, very big problem. It is not pertaining only to malnutrition. There is something behind. If you see all pregnant women in my country, in bordering Sudan and Somalia, they carry throughout their own pregnancy period a water on their back about 5 to 10 kilometers. This is to feed all the family, that is for fetching, for cooking, for everything. WHO and other branch organizations who are simply bureaucratic organizations which use 60% of the fund given to them to just administer their buildings. They give only some 40% for the benefit of these people. And this shows you the life of the woman is not improved at all. So if you consider hypertension, especially that hypertension is during the winter or rainy season in these countries. Why? Because during rainy season they plow the land, the father works on the field, the mother, she collects all the wood, everything from the ground. The way she handles herself is very terrible. It's still today. And many European countries fund these third world countries by weapons for fighting each other, not to improve the woman's life. And if you see in my country, 43% of puerperal deaths is due to sepsis during childbirth. All this together will show you the real reason, not only the riboflavin itself. If you go through the dermatologic system of the patient themselves, you can see simply where there is deficiency. Then your study will help there when you can see physical findings on deficiency. Otherwise, the main reason is they carry too much during pregnancy, that is why hypertension, and they have many infections during the pregnancy which they do not recognize. Why? Because there is immunosuppressant state during pregnancies. All this together, please, I congratulate you already, but I give you one offer again. Don't do these studies in Venezuela, which is relatively better, considering lifestyle. But if you do it in Somali, in Ethiopia, Sudan, especially the Darfur areas, you can find a very, very significant results. For this, you can ask many funders from Bill Gates, whatever, not from the WHO, because they spend 60% on the administration buildings. Thank you so much. That's
well,
all.
actually, we ran these studies in Tanzania, in Zimbabwe, and in Burkina Faso as well. But we wasn't able to complete the study.
Take questionnaires. What is their occupation? You know, they are in the field. Much of the incidence of hypertension is, and even the death preeclampsia cases in the winter time, because this is the time they plow land to grow some plants. But in the summer, mostly the children, they give birth in good time, but the deficiency of the vitamin is very relatively giving a little amount to the state. I don't undermine your study, but this will not be the main reason in the third world countries.
Thank you.
Thank you. I don't know if somebody's around on the hepatitis C paper to present. David Fontaine, Christopher Moore, or Magdalena George. If not, is one of the colleagues available who will present on the collateralization of round 2? Yes. But you have not yet.
In progress to directorate.
We'll explain, try to find out why. Okay. Any other questions? Otherwise,